50 and the numbers are low. So we'll have Dr. Joy Frida Chepchumba. Can you take it up and just tell us what is the role of caregivers in cancer survivorship?
Good afternoon, everyone. I hope you can all hear me and you can see my screen.
Yes.
So, yes, as introduced, my name is Dr. Joy Frida Chepchumba. I work with the Ministry of Health. I'm a pharmacist by profession and I have a master's degree in health economics and policy. I'm the program officer in charge of treatment, palliative care and survivorship at the National Cancer Control Program. So as Sally has mentioned, the first Sunday of June, we celebrate cancer survivors. And we had a celebration yesterday, a physical event at Thika Level 5. It was really beautiful. And we decided it's good to wrap the whole celebration with a series of webinars targeting different players in this journey. So we all know cancer survivors, first of all, are patients who've been diagnosed with cancer. So we're going to see how can you as healthcare workers support them to thrive. So a survivor is anyone living with a history of cancer from the moment of diagnosis through the remainder of disease. So from day one, when they've gotten the diagnosis up to remission, and even as they continue their lives, they're called survivors. So let's look at the Kenya cancer burden. I believe everyone so far has got to know that there's a crisis going on. There's a high increase in the cancer cases in the country. So among the NCDs, cancer is the second leading cause of death, and this is followed by, it's following the cardiovascular diseases. And in 2020, we actually recorded 42,000 cancer cases and 27,000 deaths, which is pretty high. So basically 50% of our patients were lost. And you can see in terms of incidence, we have breast cancer, cancer of the cervix, prostate cancer, and cancer of the esophagus as being the most prevalent. And in terms of deaths, cancer of the cervix is the one leading, then breast, then esophagus, and colorectal. So perhaps at this point, if it's possible, I would just like to see, as healthcare workers, what can you say is the main sign and symptom of breast cancer and cancer of the cervix in women? So let's explore what you know so far, those two cancers and signs and symptoms that may be there for prostate cancer. So if you're able, kindly post, I don't know if the chat box is open, Nelson. Are they allowed to post on the chat box? We'd like to see what...
They can post.
Yes?
Yes.
Okay. So just put on the chat box any sign or symptom of breast cancer, cervical cancer, and prostate cancer. Just one. We'd like to see at the end of this what we know as healthcare workers. So as a Ministry of Health under the National Cancer Control Program, these are some of the big milestones that we've had in the past 5 years since the program started. You can see the HPV vaccination campaign of young girls between 10 to 14 years. On the right, we see our previous president commissioning the Mombasa Regional Cancer Center. So this was the first regional cancer center to have radiotherapy services. And it's the very first one in the whole coastal region. There has never been a radiotherapy center in that area. So this was the first one, and it's up and running a year later. This was February 2022, and up to now, it's really serving the patients down there. Now they don't have to travel far. On the bottom left, you can see the Integrated Molecular Imaging Center at KUTRH. That's also another center of excellence in terms of cancer care, where you can find everything. You can find radiotherapy, surgery, chemotherapy, and even cyberknife. So there's a lot of progress. On the bottom right, this is the launch of the National Palliative Care Policy in October 2022. So this is just among the many policy documents that the ministry has launched that address the various issues surrounding cancer patients. So in terms of optimizing treatment for those with cancer, previously we are all aware KNH was the only facility offering cancer care. But in recent years, we've actually had other services being offered at the regional cancer centers and even at the two referral facilities, that is MTRH and KUTRH. And you can see they're also really busy. If you compare the level of patient visits in the three referral facilities, you can see it's almost at par. So this means if KNH was still the only facility offering this treatment, they would actually be overburdened, as we used to see before. Patients would still need to wait a whole year on the queue before they get served. So with the opening of the new referral facilities, patients don't have to wait for long. So the 11 regional cancer centers are as listed, and we have Nakuru, Garissa, and Coast General having comprehensive services. So in these three, you can find radiotherapy, you can find surgery, you can find chemotherapy. In the other 8 facilities, you can actually find chemotherapy, and some you can find radiotherapy. So at least there's hope. There's a lot of progress that has been made so far. So I'm projecting the patient visits recorded at the regional centers and some referral centers in 2022. So you can see with referral, KNH, KUTRH are leading. That is where most patients go. Shortly followed by Coast General, Nakuru, Kakamega, Meru, and Jaramogi Oginga Odinga. So you can see the regional cancer centers actually being utilized by our patients. They don't need to travel far to get the services. So as a ministry, since 2017, when the program was started, we had to set the center stage for management of cancer. So we are guided by the following policy documents that we've developed in partnership with the stakeholders in the cancer space. So we have the Kenya Cancer Policy, which is running from 2019 to 2030. So the policy is a bigger document. It can run for 10 years or even 20 years, depending on the specific policy. And from this, we got the National Cancer Control Strategy. The 2017 to 2022 is just expiring, and we already have a new one that is ready for launch. We have the cancer screening guidelines. This shows you which cancers are possible to be screened. How do you screen them? Who are your target population for screening? Then we have the specimen handling guidelines. When you take a specimen, how should you handle them? We have the treatment protocol. So this guides the treatment of cancer, the priority cancers across the cancer centers. Then we have the guidelines for establishment of cancer management centers. We have the breast cancer action plan and the palliative care policy. So it's good to note that all these documents are actually available on the Ministry of Health website, so you can have a look at them later. Okay, so from the National Cancer Control Strategy 2017 to 2022, 5 pillars were formed. First pillar being prevention of cancer, second pillar being diagnosis, third pillar being treatment, and the fourth pillar being coordination, partnership, and financing. And then monitoring and evaluation cuts across. That's the fifth pillar, but it's monitoring and evaluation and research of all the activities happening in the 4 pillars. So I'll discuss more on how survivorship is able to be implemented in all the 4 pillars. So some of the challenges that have been witnessed so far in the cancer management. First of all, patient-related, low awareness of symptoms and availability of treatment options. A patient may think whatever I'm having, maybe it's just normal, there's nothing much about it, and yet it could actually be something. Then maybe they go to a health facility. They keep coming there, they have constipation, they have maybe hyperacidity, and they're just given medicine over and over, and the healthcare worker is not thinking of referring this patient. By the time they're referring them, it's actually a bit too late. So we've seen there's a low index of suspicion among the primary health workers. Then there's deficient cancer diagnosis and treatment infrastructure, the essential cancer HPTs at KEMSA. We have low fill rates. These are poor referral systems. Healthcare workers are not aware where should they refer the patients. Then the cancer specialists that we have a good number as compared to what we had maybe 5 years ago, but it's still not adequate. Against the 42,000 cases we are having, the pool of specialists is definitely not adequate, and the training facilities and opportunities are still few and pretty expensive for most healthcare workers who would want to venture into this. Then the high cost of cancer care, I believe that's something we are all aware, and this is driven by the high cost of medicines, in particular the innovator medicines, which are more targeted, and you find most patients cannot afford this. So you see there's a lot of fundraising that we do for these patients. Sometimes they may even have the NHIF cover, but at some point they'll still need to top up with cash. So these those challenges of the cost of care. So on Cancer Survivors Day, we would like all cancer survivors to have a life with less complication and more celebration. So the framework for survivorship, we have the cancer survivor level, the healthcare system level, the society or policy level. And some of the areas that the cancer survivor will have needs, the physical well-being. How are they feeling? How are they sleeping? Any pain that they're experiencing, fertility issues. Those are some of the physical issues that as healthcare workers, you will need to look into. How about their psychological well-being? Are they depressed? Are they having cognition issues? Are they having anxiety? And who do you call in such a case? How about the social well-being? How is their family? How is their sexual function? How is their employment? Do they have a source of income? Do they have a support system, or they're isolated? All this will affect a cancer survivor. Spiritual well-being, this is also very important. The spiritual well-being of a patient gives them meaning, it gives them hope, it gives them the inner strength. So this is also something that a survivor will need. So as part of the NCCN post-treatment breast cancer surveillance guidelines, you'll find there are some practical things that as a health worker, you can actually follow up. For breast cancer patients, they'll need a history and physical exam every 6 months for 5 years, and then after 5 years, every 12 months. The annual mammography of preserved tissue will also be useful. They need to be on tamoxifen and gynecological assessment every 12 months if the uterus is present. So there are some of these issues that will be long-standing. So when you see a patient who's come to you, maybe even in a lower facility, ensure you've taken the full history, know what the patient is currently using post-cancer treatment, or if they're actively on treatment, what are they using, so that you can correlate maybe some of the symptoms that they have to the treatment that they are taking. Also, issues such as the active lifestyle, maintaining an ideal body weight. These are all important, not just for breast cancer patients, but also across all the survivors. For prostate cancer treatment, some of the complications that you may come across, the patient may have sexual dysfunction, they may have bowel incontinence, urinary incontinence, radiation, proctitis, and diarrhea. So all these things are side effects that happen during treatment. And since the patient may be referred down to you, you may have to see how to alleviate some of these complications. For colon cancer, you may find these patients have fecal incontinence, they have abdominal adhesions, they may have radiation proctitis, they may need to have ostomies. I think you've heard from our moderator of the day. She's one of the people living with an ostomy, and it's something that many healthcare workers are actually not trained to handle. We've trained a good number of them. They're able to handle this, but there's still a gap. So it's good to have that awareness among healthcare workers of these complications that these patients may have, even post-treatment. For childhood cancer survivors, I hope we're all aware, even children can get this disease. So they may have some long-term risks, such as periodontal disease. They may have cognitive dysfunction. They may have endocrine abnormalities, chronic lung disease, osteoporosis, impaired growth, and they may even have secondary cancers from radiation and chemotherapy. So some of the essential components of survivorship care, I'll go through 6 major components. So the first one is education. As healthcare workers, we need to have a care plan for the patient, considering present and future effects. This education needs to cover a healthy lifestyle, and the whole oncology team should be part of the care plan. Then there's the surveillance that needs to be done on these patients to see for cancer recurrence. This is the primary cancer recurrence or other secondary cancers, any long-term adverse effects. Then how is the patient wholesomely? The physical, psychosocial, socioeconomic effects. Then we need to look at the interventions, prevent or treat consequences of cancer and its therapy. And this includes such things as wound care. As I've mentioned, if a patient has the ostomy, this is something that you need to handle very carefully. You need to be trained on how to handle this. You need not to be afraid of that patient. You need to handle them with kindness. So some of these interventions that you need to do as a healthcare worker, wherever you are, will be essential in this package. Then communication. I think we cannot emphasize this enough. There needs to be communication. The patient may come to KU or MTRH, but they live in Kitale, they live in Lodwar, yeah? So how is that primary healthcare worker aware on what the patient has been put on what they're supposed to be doing? There needs to be that communication between the specialist and the primary care provider so that we can have continuity of care. We need more research in survivorship to understand prevention and treatment of adverse events of cancer. Then we need patient advocacy. We have a lot of support groups that are doing this already under the umbrella body of KNH, and we partner with them in the Ministry of Health to just see how to address some of these issues that the patients are facing, including employment, insurance, disability. So in summary, the patients will need to be checked for recurrence of the primary cancer. Then they'll need to be screened for development of a secondary primary or a secondary primary malignancy. So screening may be useful for the general population, but even for these patients who have already gone through cancer, you still need to screen them because they may get another malignancy. They need to be checked for long-term physical effects of the treatment, psychosocial consequences and treatment. This patient always lives in fear. What if it comes back again? So we need to have psychosocial support for these patients. Then we need to ensure that they maintain wellness. This includes proper nutrition, proper weight, adequate movement, depending on the status of the patient, and a good social support. So this comes from the family level to the society level to even the healthcare providers. This is a way these patients come to a certain facility and they just feel very welcome. They feel the staff in that facility are really taking good care of them, and that really helps the patient in survivorship. So the National Cancer Survivors Day is a celebration of life, but it is also a call to action. So let's see some of the actions that we are asked to consider during the National Cancer Survivors Day. So under the first pillar, we said first pillar is prevention, early detection, and screening. So what is the role of the healthcare workers under this? The first point is on health education. How are we talking to our patients on maintaining a healthy lifestyle, on the need to do regular screening, on the need to come to hospital when they have any worrying signs and symptoms, on the need for vaccination of the girls 10 to 14 years. Are we talking to them about this? Are we doing screen and treat? I believe a good number of you have heard of this program where we are training healthcare workers on screening and treating of cervical cancer. And this is for the precancerous lesions. And we've seen a lot of patients being helped because when they come to the facility, they actually don't have any symptom. But if you do a screening on them, you'll actually see there's some lesions already developing on the cervix. And this can just be addressed at that point when they're not yet cancerous. And as a healthcare worker, when you see a symptom that is persistent, do you query it? Do you refer in good time? Do you create awareness maybe in your population on the things they need to avoid, things like smoking, things like excessive drinking of alcohol, being overweight? We all have a role to play in prevention and early detection of cancer. Second pillar, which is on diagnosis, registration, and surveillance. Still the first point comes in health education. These patients need to be educated before you refer them for the diagnosis, and even as they're receiving health professional, you need to also give them the health education that this is what we are querying, this is what we shall do, these are the tests you'll undergo, what is expected of the patient. Health education is really, really important. It makes a big difference for these patients. So the healthcare worker will need to request for, there's some basic tests that can actually be done at your level as a primary health worker. And some of these tests don't need to be referred. You can just do a peripheral blood film and you'll see something that will guide your next steps, which is a referral to a specialized center. The healthcare worker will also need to do accurate specimen collection and handling. We have the National Cancer Reference Lab here at the KNH complex, and they're able to receive specimens from across the country, and they process them at no fee. But you'll see some of the samples coming there are not well sampled. There's no clear margins. So there's some gap in this, and we are all aware it's not fair to bring back the patient again for another sample collection. It's expensive. It's painful for the patient to undergo the test again. So as healthcare workers, we really need to get accurate specimen collection and handling. Then we need the proper diagnosis, and this is done through the specific tests that need to be done for each of the patients. So under treatment, palliative care and survivorship, what is the role of healthcare workers? Number one, again, patient education. These patients may have now reached the cancer center. They've come from the lower levels, they've been moved, now they've reached at KNH, or they've reached at MTRH, KU, or Nakuru. So the first thing, do you take your time to tell the patient, this is what has been found, this is the plan we have, Sometimes the patient just needs the first session to just be just an overview, not even being filled in with too much information. And you may find you may be the first person to actually break the news to the patient. How do you do that? Do you involve the palliative care team? They're very key in this. They know how to break the news to the patient, because from here, if it's not well done, the patient may actually disappear and not come for treatment until they've gone and tried other things. They've gone to the traditional healers, they've gone to the priests and to the pastors, and they've been given oils and what. By the time they're coming back, it has advanced. So from that first contact, the way you handle that patient will make a big difference. So as healthcare workers, you need to work under the multidisciplinary team, where you'll plan the treatment, which is specific for that patient. We need to strengthen the health systems, whereby the patient will have access to affordable equity treatment. We need to have specified clinic days so that the patient has an easy time. They know when they come to this clinic, get the supplies. We need to stock up the drugs needed, the equipment needed for this treatment and for the various interventions. We need to have a comprehensive team. And this is not just the clinical team that does the treatment. We also need the supportive team, the palliative care, the mental health specialists, the nutritionist, the spiritual leaders. And we also need the team that is keen on sexual health of the patient. Under partnerships and coordination. As healthcare workers, I believe a good number of you know the technical working groups that the government, the Ministry of Health works through. So we all need to be part of this. And as a ministry, we always try to involve the county participants to just know what the national is thinking and to advise us. So some of the partnerships that as a ministry we've been able to collaborate so far, we've been able to establish the National Oncology Dashboard, whereby supply chain management, quantification, and forecasting is done for the oncology medicines across the country. We've been able to develop the cancer treatment registers and summary tools. We've also been able to have some private and public partnerships, which have led us to 2 major access drug programs. And this is the Glivec Access Program. This is for CML patients. It's been running at Nairobi Hospital for over 15 years. And now it's been decentralized to Nakuru, Kisumu, Coast General, and MTRH. And over 200 patients have been able to be seen at these new centers. And for this access program, the patients don't pay for this drug. It's actually being donated by the Max Foundation, and the patients are able to access the drugs free of charge. They only pay for the lab tests that are required or any further investigations. For the Herceptin subcutaneous access program, this is a new one, and this started last year. And for this, Roche was able to give the ministry a very good deal, whereby the patients are not topping up any more for this drug. The price offered is able to be covered fully by NHIF, and we've seen a lot of good things coming from these partnerships. So some of the work that is ongoing in survivorship, there's expansion of diagnostic and treatment infrastructure. As I mentioned, we already have 11 cancer centers, 3 of which are comprehensive centers. And in the next few years, we will see more other centers coming up. The oncology package in the UHC benefit package, we are working on it to ensure it includes screening and diagnosis. Then there's awareness creation that is being done. There's capacity building among the primary health workforce. We are addressing commodities and supplies for cancer management and rehabilitation. Then we are trying to improve the quality of care through sensitization of the health workforce on what needs to be done. Then we are strengthening surveillance, occupation safety, and health of the staff, as well as research and training. So we all know, as we've mentioned, the cost of treatment is very expensive. So some of the policies that the ministry has actually initiated so far, since 2019, the ministry has been able to supply some chemotherapy drugs to the regional centers just to alleviate the shortage of these drugs. We know they're very expensive, and sometimes getting a budgetary allocation towards this may be difficult. So the ministry has been supporting that. And currently we have 23 essential oncology drugs that the ministry has supported to the level whereby the patient does not get charged for this. So for these drugs, the patient will not be charged, even if they have NHIF. The facilities are able to give them at no cost, so that the cover can be spread out to cover the rest of the drugs that the ministry has not been able to cover, and the rest of the tests, which include even surgery that will be needed, radiotherapy. So there's that. Then there's the morphine access that is being coordinated across the country. This is also a drug that the facilities don't charge the patients, and the reconstitution plant is actually done here at KNH, and the tests are also done at Daru. So there's quality reconstitution of this morphine. So previously I'd asked you to name some of the major signs and symptoms of breast cancer and cervical cancer. And this is because some time back we had asked some health workers from Busia and Trans Nzoia to just give us some of these, at least just one of the causes of, or the risk factors for breast cancer and cervical cancer. And we're actually quite saddened that very few of them knew these risk factors, and yet we handle these patients every day. So I can see there's good information. I can see for breast cancer, people are saying there's there may be a lump on the breast. Many people have said that. Nipple discharge. Then there's vaginal bleeding, painful lump, inverted nipple, vaginal discharge, abnormal discharge from the breast. Someone has said back pain for prostate, round lump, prostate. Someone has said hesitance in menstruation, slow flow of urine for prostate, breast lump, cervical cancer spotting, painless lump, rash on the breast that doesn't go, a lump, cervical cancer, discolored discharge, postcoital bleeding. This is all very good. So from all this, you can definitely see this is a patient who comes to you, maybe even for family planning. One of the things you can ask them is, can I examine your breast? And maybe when the patient does not know how to do the self-breast exam, that's also something you can teach them. Because some of this lump, you may not even feel anything. And we know by the time you're starting to have any pain or any symptoms, that disease is definitely advanced. So as healthcare workers, let's create that awareness. Let's give the education to the patients so that if they see anything that is not of that is not normal, that they should always ask. And sometimes they may even think it's a normal thing. So it's up to you as a healthcare worker to think of these symptoms and ask them, do you normally have this? Do you have this? Do you have this? How is your urine? How is your stool? From the questions, you'll actually maybe probe the patient further to know something that is not right. Okay, so from this PIC4C study that was done a while back, the ministry decided to have some training on the signs and symptoms of the priority cancers. And we have a web-based platform and a mobile application with all these signs and symptoms of the priority cancers. So I believe a good number of you know the MOH Virtual Academy. So if you go there, you'll find the early diagnosis of cancer course. You're able to go through the different cancers. You're able to get the CPDs and the certificates. And if you'd like to use it on your phone, you can have the M-Saratani app, which is downloadable from the Google Play Store. Some other trainings that are going on, I've already mentioned the screen and treat training in the 47 counties, whereby they train on breast and cervical cancer. We have the ChemoSafe trainings on the safe handling of chemotherapy. We have the supply chain management training that has been done for the pharmacists in the regional centers. We have data management trainings that have been done, specimen handling training, as well as cancer advocacy training. And all these are very useful. This patient will pass through your hands, all from the primary health worker to the specialized facilities. So the training is offered all the way from the lower levels to the specialized centers. Okay, so I'd just like to end with this, that kindness is a language which the deaf can hear and the blind can see. So let's spread kindness to our patients as they come to our facilities. Let's be kind to them. This journey is not easy. It's a very fearful journey for patients and their caregivers. So let's all be kind. Thank you.
Wow, thank you so much, Daktari. That was very elaborate. I'm just imagining that is a course that could have taken a whole year and you've done it in 30 minutes. So there are so many questions coming on the Q&A section, but I would suggest that we finish first and then we can tackle the questions. That is, if we shall have time. I now would wish to welcome Dr. Esther Shege Munyoro. She's a pain and palliative care specialist. Daktari, we really miss you at Kenyatta, and let's hear from you. Karibu.
Okay, good afternoon.
Good afternoon, Daktari.
It says you can't start your video because the host has stopped it. I don't know. I want to share my screen. So can you allow? You can see my screen, yeah? Hello?
Yes, Doc, we can see your screen, yes.
Fine. So let me introduce myself. Of course, I've been introduced. My name is Dr. Esther Munyoro. I am a pain and palliative care specialist. I retired from KNH. So like Daktari has talked about, supporting cancer survivors, I will just continue. I will repeat a lot of what she has said because I didn't know the order in which we shall present. So you've had the definition of a survivor. And of course, I don't know whether you're like me who thought that survivors are those, you know, you go for the cancer treatment, and after you're finished, then you're a survivor. But then I learned that survivorship starts at the time of diagnosis and proceeds along a continuum through and beyond treatment, cures, recurrences, and the final stages of life up to death, regardless of the cause. So that an individual is considered a cancer survivor from the time of diagnosis to the end of life. So with that in mind, we have been told to talk about what does a survivor thriving mean? So how do we want to assist these survivors? We want them to grow, that is to flourish. We want them to gain in wealth and possessions. And we want them to progress towards or realize a goal despite or because of the circumstances. I must say that in our setup, we have very many survivors who have managed to do all these three. But as healthcare workers, we need to be able to look to them and think, I helped them get where they were going. And so what we would like to discuss is how do you help survivors? Somebody from the day they were diagnosed up to the end, how do you help them grow, gain in wealth, and progress towards a goal despite them having had cancer? So there's currently limited amount of research. I'm trying to remove this, I don't. There's a limited amount of research regarding cancer survivors, expectations and experience with their care following primary treatment. There is reports of general dissatisfaction with post-treatment care, with many survivors reporting little attention being paid to their many concerns. And when evaluated, problems in survivorship appear to stem from a number of things. One is lack of coordination between the primary care provider and the cancer care provider. So when you come from, let's say you're coming from Lamu, you're sent to KNH. When KNH is done with you and they send you back, there is lack of coordination because we are supposed to be able to tell whoever is taking over, this is what we want you to do for this patient continually. Now, survivors themselves are unaware of the health risks and the issues they face, and they are usually not provided with a plan for follow-up after treatment. And then there is a growing population of survivors, which means that we have more people at risk of recurrence and second cancers. And what does that mean? That means we need to improve our cancer care, because if the population is growing, then we actually do need to have ways of taking care of them. And what are the barriers? So, like I said, the primary caregiver and the cancer caregiver are not communicating. So we have a fragmented and poorly coordinated healthcare system. So it's good that we are starting all these centers. We want to know how they are coordinating. How is the cancer care treatment center telling those other district hospitals, whoever has sent this patient, how are you passing on the information? And it's we get better at it if you send information back to the district hospital or whoever sent them and tell them, okay, you send this patient who had a discharge from the breast or who had a positive biopsy, and this is what we've done. We've gotten them to this place, take them back, look after them. Should you find these complications, bring them back to us. So that fragmentation does not help. There's an absence of locus of responsibility for follow-up care. So that I used to be in palliative care. Very many people used to walk in, not because they need palliative care, but because they were treated, they were allowed to go after they were seen once. They were not given an appointment back to KNH, but they really want to ask their oncologist, you know, this new thing that they have, is it connected to the cancer they had maybe 10 years ago? So somebody needs to be given this responsibility for follow-up. And then there is a lack of guidance on how cancer survivors can maximize their own health outcomes. Then, of course, there is the barriers that go with the healthcare worker. They're not having the necessary tools to provide consistent quality care, such as evidence-based clinical practice guidelines. So we should have, you know, some form that somebody gives you. If you have survived breast cancer, it tells the healthcare worker what they're supposed to do for you, and, you know, we follow those guidelines. The providers also lack delivery system support, such as information technology, that would allow them to overcome some of the obstacles posed by the fragmented nature of cancer care. So those are the barriers. There have been some research done. This is one that was done on unmet needs of the patient with cancer. And this was listening to survivors. 53% reported secondary health problems and other problems like chronic pain, sexual dysfunction, relationship difficulties, fertility issues, fear of recurrence, depression, financial and job-related concerns, 49% of them had non-medical cancer-related needs not met. Now, this tells me that we need the hospitals to employ more counselors. So the day I see that there are enough counselors in our hospitals, there's a sex therapist, there is somebody to advise you with your finances, then we will know we are really helping the survivors. Now, when is survivorship care practical? You see, if you're diagnosed with cancer and I start telling you how to invest, really and truly, I'm not helping you. So there is a point at which survivorship care is practical. And it is that blue area that you can see. And that is when there is cancer-free survival, when we are managing a chronic or intermittent disease. And when people are there in that point, then they can actually concentrate on survivorship. And that is when people do not actually have support, because if it's the diagnosing stages, they will have their oncologist. If it's the treatment, if there's treatment failure and they need to go into palliative care, if it is end of life, they might have hospice care. And when they get out of that and they get a recurrence, then they go back into the healthcare system. So this is the area, this blue area is when we need to concentrate on practical management of survivorship. So what are the essential components of survivorship care? So the first one, there are 4 components, is intervention for consequences of cancer and its treatment, including medical problems, symptoms, financial and psychosocial distress. So this would be the first component of managing survivorship. The second one is coordination between the specialist and the primary care provider to ensure that all the survivors' health needs are met. The next one is surveillance for cancer spread, recurrence, or second cancers. And then the fourth one is prevention, education for behavioral lifestyle changes to reduce the risk and to prevent new cancers and recurrent cancers. So all this you had heard before, but I'm just summarizing them into the 4 components. And for that, people need to have survivorship care planning. So what is a survivorship care plan? This is a plan that will inform the patients and the healthcare providers of the ways to monitor and deal with possible short and long-term effects of cancer treatments. It will include getting a comprehensive care summary and follow-up plan. That summary should be clearly written. It should be effectively explained. It should be written by the principal provider of the oncology treatment. And we should get some reimbursement by third-party payers of healthcare for survivorship care. And this is because if you're having medical cover, but they're not covering your survivorship care, then they tend to be people not taking enough interest in it. So that space needs to be created and it needs to be cared for. Now, when you get that summary from your doctor, and we are saying it should be the oncologist, because they need to tell you the cancer type, they need to tell you the tumor characteristics, the site, the stage, the treatments that were received. It really needs to be detailed, because it doesn't make sense when you see a patient and they just tell you they had cancer. So you actually don't know whether this is a recurrence, whether it is metastasis, whether, so people need to be given summaries that give all the information necessary. Again, you are told about the survivorship follow-up plan. When you have been diagnosed, let's say with prostate cancer, you need to be told the intervals for which you should come for visits. You need to be told what tests you should come. You need to be told who is the provider who should see you. So when you're given that summary, it must be very particular who you need to go on to. So this should be booked. They should be booked appointments, and we should be able to follow you to ask you why you did not come for appointments, because most people will be diagnosed, they will be treated, And the next time you see them is when there's a recurrence or when there's a second cancer. But in between there, they actually never went to be seen in any hospital. Then, of course, there is this chart where you can actually get survivors to assess themselves. This is the patient version, where they can, by just looking at the concerns, you can tell them these are the things that they need to follow. And then they can come to you if any of these things are bothering them. So like, depending on what chemotherapies they were given, there is cardiac toxicity. And these are the questions: do you have shortness of breath? And that kind of thing. And then of course there is, no, I don't know. There is anxiety, there is lymphedema, there is pain, there is sexual function. We tend not to concentrate on sexual functions, but this is something that comes out later. People lose their relationships, people lose their body image. And some of these things, if we took an interest in them, we could actually help before people get into problems. There is sleep disorders, and then there is healthy lifestyle, and of course, immunization. It's very rare that you will find cancer survivors who are aware of all the immunizations that they need to do. So there are those that are recommended, and this is the NCCN guidelines. There are those immunizations, vaccines that are recommended for all cancer survivors. And then there are those ones that are recommended in special circumstances. So these are things that survivors need to know about. Then, yeah, we talked about assisting survivors to modify their lifestyles. So this is about getting the nutritionists to actually help the healthcare providers. Healthcare givers can help to maintain and enhance wellness in cancer survivors, including those who are enduring ongoing treatments, those who have completed cancer treatment, and those in clinical remission. So as we are setting up these cancer centers, we have to make sure that we have the specialists who will help patients modify their lifestyles. And then, of course, genetic testing. Genetic counseling and testing, again, is not a part of our system. But I find it very sad when I interview patients and they tell me, yes, my mother died of breast cancer, but they were not aware that there is a small risk that was to them, because by then they would have learned. So in fact, when I get family meetings, and of course, when you attend those family meetings, a lot of people are coming there to ask you, is this disease contagious? But it's not about it being contagious. Sometimes it's about the genetic factors. And a lot of people are very receptive when you're talking to them about their dying patients. If you can then introduce them to what they need to do, what are the health lifestyle they need to have, what vaccinations do they need so that they protect themselves from cancers. So who should receive survivorship care? Every individual should receive survivorship care following their treatment. The need for specific services will vary from survivor to survivor, depending on the type of cancer and the late effects. Survivors of early stage cancer whose treatment was limited to surgery may require minimum follow-up, and survivors with more advanced disease who have been treated with surgery, chemotherapy, radiation, and hormonal therapy may need long-term rehabilitative and supportive care. Some individuals treated for predisposition to cancer may also benefit from survivorship care, and those are the ones who have genetic mutations. So what I am saying is that patients don't fit into boxes, so we need to decide which service each patient should be given. So this is a summary of cancer survivorship post-treatment phase. So there is a prevention, which should go to the survivors and the family members by promoting healthy behavior. That's the physical activity, the diet, smoking cessation, and other lifestyle changes. Then detection, survivors and families. So the survivors' adherence to follow-up care, screening for second cancers, and screening for related conditions. And then, of course, there is the survivors with the side effects and late effects. And that's treatment management of side and late effects. Now, if you look under, you'll see the family. So the family does get affected, when somebody is diagnosed. So they can get screening for high-risk families. And of course, there is the psychosocial and caregiver burnout that they also do need to be supported through. Now, the other question is who should provide survivorship care? So survivorship care can be provided by either specialists or primary care providers. These providers can come from various care backgrounds. They can be physicians, nurses, psychologists, or social workers. But optimally, a designated individual should be responsible for coordinating survivorship care, and care is viewed as a shared responsibility. Cancer survivors should be informed care partners, but providers within the healthcare system must take primary responsibility for coordinating care. So I would suggest that we need to have survivor nurse practitioners. So it can be an independent nurse practitioner visit, it can be a nurse practitioner service for surveillance for recurrence of the primary cancer, evaluation and treatment of medical and psychosocial consequences of treatment, screening for second cancers. These nurses can also do patient education about survivorship issues and availability of community resources. They can also help with health promotion, including smoking cessation and the sexual health services. They can also help with communication with the community physicians, and they can also help with getting the cancer treatment summary and the survivorship care plans. Now, this is to show you, this was patient navigation program that we started in KNH. Of course, when we were first told that a navigation program would help patients get through the system, we actually did not know how much extra we could do for the patients. But once we did it, we realized that whichever service or program you want to offer, you actually do need to designate people who do that. So we got navigators who are nurses, who their only work was to navigate people through the cancer treatment plan. We got equipment. We got an office. We started a website. People were getting lost. So what did we need to do? We needed footprints and signage. We needed to educate the patient. We needed patient folders. Now, if a patient has a folder, a patient comes and pays for the x-rays, for the MRIs, there's no reason why, if they are to travel from Kenya to India, they should not go with a summary of everything that has been done for them. Of course, once we released this file, the patient said they didn't want the cancer treatment center. They didn't want it reading so that everybody in the matatu could tell they were undergoing cancer treatment. So I don't know whether we were supposed to change that to CTC or something. But also that stigma that a lot of people carry also needs to be worked on. And of course, there was the dream of the Hope Hostel. Again, survivors, for them to do well, for them to be healthy, we need to look into their sleep. When they come, they should finish their treatment because they know they have somewhere they can stay and they will be looked at. So I want to suggest that if we're going to have survivorship working, we need to have some foundations laid down that just concentrates. And we have survivorship nurses, practitioners who do nothing else but support survivors. So this is a summary of this study, Lost in Transition, cancer patient to cancer survivor. So what did they say needed to be done was to establish survivorship as a distinct phase of care, implement survivorship care plans. We need to build bridges between oncology and primary care. We need to develop and test models of care. We need to develop and evaluate clinical practice guidelines. We need to institute quality of survivorship measures so that we know whether we are doing the right things, whether we are going in the right direction. We need to strengthen professional education. We need to expand the use of psychosocial and community support services. And we need to invest in survivorship research so that the final message we give to survivors should be, you're meant to thrive, not just to survive. Because most of our survivors are just surviving and they are really just lost and not having a care plan. So thank you very much.
Thank you so much, Dr. Ari. That was very elaborate. And so I hope we are learning so much about survivorship. There's so many things that I'm hearing that I, as a survivor, didn't know. For example, that we need to have some vaccines and things like those. So now I would take this opportunity to call upon Humphrey. I don't know if Humphrey is in the call to just share your experience. Humphrey, are you there?
Yes, I mean,
Kindly let's hear what your experience is. I know it's not easy for men to speak, but we hope that God gives you the grace.
okay, good afternoon, everyone.
Good afternoon, Humphrey.
I'm Humphrey Elisha Juang from Kisumu, a student at Eldoret Technical Training College. I'm a cancer warrior, a cancer survivor. Even though the journey was not hard, the journey was not easy, but through my effort and courage that I had with the doctors at KNH, who worked tirelessly to make me who I am today. I'm a cancer survivor, I'm a cancer warrior, and I thank God for that. And I've learned something that cancer survivors are just not meant to survive, but they're also meant to thrive. So I'll put that into consideration. This journey was not easy since 2019. It was 2018 when I was diagnosed with lymphoma, Hodgkin's lymphoma. And I went through the chemos, even though there were side effects. And after side effects, after the chemo, when I went back home, there was some stigmatization, people avoiding you. And then family finances went bankrupt because of the medication. But due to support that I had with the empathy people and the caregivers, made me who I am today. So my question is always about, after this treatment, after surviving, how does that chemo or cancer, how does it affect the hormones, human hormones, let me say in productivity? So that one is something which is always disturbing me a lot. And another thing is, will this disease come back again? And what if it comes back again? What should I do to prevent it again? Yeah, but the journey was not easy, but to the courage I had, and I do believe that I'm a conqueror, I'm a victor. I will win the race. So I did win the race, and thanks to my doctors. Thank you.
Thank you so much, Humphrey. Indeed, you are a warrior.
Thank
And
you.
just as Humphrey says that the fear of recurrence is in us survivors, because especially if you're in a group and you find out that someone has shared their story that I was treated for cancer and it has come back again, and then another one. So that's a very big concern. And again, even as Humphrey is talking about the issue of bedroom issues, like should I still be in the same bedroom with my spouse? For example, in my case, having a stoma, as I had said, stoma bags are not readily available in Kenya, and if you find, they're very expensive. And I've experienced patients being divorced or just being thrown out of the home, that we cannot stay with someone who's smelling. So there's a lot of issues that surround survivorship. And I like the way Dr. Munyoro brought it out so well, that we need all this support to surround us, especially after I've been treated and I'm okay. How am I accommodated back to the society again? So let's also hear from my good friend Lucy Jerry Karaoke. Kindly share your story with us.
Good afternoon, everyone, or good morning, wherever you are. First of all, I want to say thank you very much to Dr. Munyoro. There are things that I've learned and heard and seen for the first time as a survivor. So it was very, very educative, and I wish, because there are many of the survivors outside there who cannot or don't have the devices to join to the webinar, you can go physical. You call a meeting, you talk to these people and tell them 1, 2, 3, 4, 5, because I'm aware that not all the survivors have the capacity or the capability to join these webinars and learn. It was very, very educative, and I feel very empowered. Thank you very much. As Sally has said, my name is Lucy Njeri, and I'm a breast cancer survivor. This is my 7th year. I'm on remission, and I developed passion to do advocacy and to speak loudly about cancer. Not because I have the loudest mouth, but I believe my voice and Humphrey's and Sally's and another person's voice, we make a force. And that force is the one that is going to bring about change. We only talk about surgery, chemotherapy, radiotherapy, and hormonotherapy. That is it. But where do we go, or where are we? Thank you, Humphrey, for bringing up that issue of the bedroom. There's another day that I challenged the doctors and told them that behind these doors, things are not going well. Because as doctor has said that sex dysfunction is real, and marriages are breaking, and people are moving out. People are not just having the trauma of being sick, diagnosed with cancer, trauma of the pain and treatment and financial, but even in the society, when your husband goes out and gets somebody else because you cannot satisfy his or her needs, that is a case that is really rising, and it's bringing up things that we don't love. People are here who want to get children. They already are infertile, or you started the treatment and things went to mayhem. You can't get children. Where are we? People are staggering around. People are here. They don't know where to start or where to go. They don't know where they're beginning or they're ending. We are once somebody who used to do her own things. You're in business, you're employed, and after the cancer diagnosis and treatment, you are laid off, your business went down, you don't know where to start. And eventually people move away from you. And people tend to think that when you're through with treatment, you are okay and they all leave. In fact, that is when you really need them. The support system is one of the key things that people lack during this journey of cancer. I'm glad I got a good support system, not only from my family, because by then my mom was ailing, but the society that was around me. I got a good support system. They supported me where I was going down, and I was able to come back. And why we are speaking about survivorship is because people tend to think that we are very strong. Indeed, we are very weak. We have scars and we have pain behind our smiles and what we talk about. When you get into that person's shoe or talk about, or let them talk about what is happening, you'll be scared. The scare is big. Recurrence, that is one thing. All of us are scared and it's very fearful. Let nobody tell you that they are not fearful. We are. In fact, you don't want to feel a reason or something that it's directing you to having a reoccurrence. It's fearful. Anxiety. You don't know what to happen. This minute you're here, the next minute your friend who you are working with has gone. And it is real. People are dying. All of us are candidates of death. But given a cancer diagnosis, most of us, the society tends to push us, nyinyi mnakufa, nyinyi ondokeni. So I would love Dr. Esther to come to the ground. Please, if it is possible, come and talk to these patients, come and tell them, let us know our right. I've seen that people have said that they're essential drugs, something that most of the patients and survivors don't know outside there. The treatment plan, don't know, we are not included. And I would like to say that survivorship is a pillar, a very important pillar, and a tool to link the gap between the health system and the patient. Because for one, they're the ones who are navigating these people. We are the ones who are telling them the experience as it is, because we call ourselves the specimen. The doctor will tell you your hair is going to fall down, but they don't know how it feels for the hair to fall down. I have the experience. The doctor is going to tell you this treatment is going to bring about nausea, diarrhea. They really don't have that experience. So I have. So these people have built, the patients that are around have built a confidence around us. They even share their diagnosis. Ebu nisomee hii, daktari anasema nini? Because as we understand it in a more simpler language, it is very good. You went to school, you did what you did, but I think inclusivity, now let's work between the doctors, the survivors, and the patients, and the results will be amazing. Thank you very much.
Lucy, did we lose you or you are done?
I am here. So I got my treatment at KNH. I don't have a breast. I'm a one breast woman. I did my chemos, I did my radiotherapy and surgery, and the NHF came in for me, although I had to do some out of pocket, which was for radiology, the X-ray, the mammography, that was cash, and the queuing at Kenyatta. But one thing we say is that Kenyatta itaki makasiriko. I'm happy that they've really devolved the cancer care in Kenya. We don't have, during my time, I had friends who came from Mombasa all the way to KNH, from Nakuru. At least with the development of health, we are heading somewhere. Thank you very much.
Thank you so much, Lucy. That is well put. And I agree with you. I echo your words that please, Dr. Munyoro and even Joy Frida, please, can you, if we arrange a session for us survivors in the different support groups, we can just arrange a big forum and you come and share that information with us so that we're also aware what is for us. Thank you so much. So our last speaker for this webinar will be Esther Njonge, who will also share her experience. Esther, karibu. Is Esther with us?
No, Sally, Esther,
Yeah.
Esther didn't make it.
Or she didn't make it?
Yeah.
Okay, so I think then we could take some
Can I add something that now Esther was not there? I was cutting myself short to give Esther some time. Give me 5 minutes,
okay.
Sally.
2 minutes, please.
2 minutes, thank you.
Summarize,
We also need to look after survivors' well-being, mental health. The trauma that people go through after a cancer diagnosis is not easy. I salute you, Sally. You can go way, way beyond, but for me, some of the things that you do, I can't do. And for survivors, some of us have not healed. Health, emotional healing, and mental healing are key components that are missing. Cut, poison, and burn is okay, and it is everywhere. And also counseling. We don't have enough counselor. During my time, nobody told me that, Lucy, come here, 1, 2, 3, 4, 5. No, I just went into the system. I know things are changing, but the number of patients against the cancer way beyond. Let's give hope and create hope. Thank you, Sally.
so much. Thank you so much, Lucy. You summarized it so well. It is true, as you say, that the emotional bit is an area that needs to be looked into. I personally attempted suicide, and I know it's not a joke, especially the way the news is relayed to you. Another thing that I would raise, I know that now we have the medics in this forum. There's a language that you commonly use that the patient presented late. But the truth is that I was coming to the hospital, like let me talk for the group that I ran. I ran a support group of over 100 people who've gone through colorectal cancer. So they say that I was being treated for H. pylori. I took maybe 3-4 kits and nothing happened. I was treated for ulcers. I was treated for typhoid. I was treated for amoeba. And for over a year or two, and suddenly I'm told I have stage 4 colon cancer. So, and then the notes, the doctors are very fast to write. I really appreciate doctors, by the way, and you saved my life through God's grace. But there's this thing you say the patient presented it. All this time I was coming to the hospital, you were treating something else. And as Joy Frida was presenting, how about thinking about, okay, I've taken a first kit, second kit. How about just doing a colonoscopy? I know it's not good to rush and tell a patient that now we are suspecting cancer, but it's better to start early. For us, it was started early, and that's why we even survived. For example, in my case, I had stage 2 cervical cancer with no symptom at all. Like I've seen, you've listed some of the symptoms for CS cervix. Mine was nothing. I didn't experience anything. And I was at high risk because I'm also living with HIV. So they had to do a very fast intervention of doing a total hysterectomy, and I survived. So can you also just think about cancer, even if it's not necessary, so that we save more lives? Because we are getting so many people joining our support groups every day. Another thing that I don't know if we have researchers in the call, but we are finding that when people are going for treatment, some are not even finishing the chemotherapy sessions or the radiotherapy sessions. They're dying in the process. So is there something that has been put in the drug or something that has been removed from the drug? Because we find that the treatment now, people are really reacting, and we are seeing so many fatalities. Yeah, so if we can now maybe go to the questions. Dr. Joy Frida, do you think we can do some questions in maybe 10, 15 minutes?
Yes. Let's address the questions.
Okay. Okay. So I'll read one question that says, I have a long-standing patient with adenocarcinoma of the rectum whose diagnosis we made in 2004. She has sigmoid colostomy. I can't call her a survivor because at diagnosis it was already advanced but never received any anti-cancer therapy. I would like to link her to the organization run by Esther. She is from Bungoma but lives in Vihiga. Dr. Amaganga, kindly get in touch with me. I'm actually the one running the support group. It's called Kenya Ostomy Association. So you can link up the patient with me and we can help her. So there's another one, the acute need for specialists in wound care, in wound ostomy care. I totally agree with Mary. Cancer patients have very complex wounds that need healthcare personnel who have skills and knowledge of wound ostomy care. Mary, I agree with you because we are working very closely. And I would say that personally, I know over 100 nurses who have been trained, even in your own space. But again, the challenge we are getting here on ostomy care is that we don't even have those appliances. Like a patient comes to you and has a wound, a stoma wound. You may have the skills, yes, but you don't have the appliances to help this patient. So as much as we're also focusing on personnel and training them, can we also offer the appliances that are required to help them, especially in the wound care? There's so many questions coming in. Okay, there's someone who's saying there was mention of M-Saratani app. It doesn't appear to be working. I cannot register an account. Dr. Joy Frida, you think you can help us with that? How do we access the M-Saratani app?
Okay, so kindly check if you had the previous version of M-Saratani, kindly uninstall and install the one that is newly created. It should be under, let me just read the provider so that you don't get the previous version. So look for the one written Health Strat. That is the new one, and it should be opening with no challenges. Okay, thank you.
Okay, Robert is asking that when do the trainings happen and where?
So for the trainings, they're usually organized in the counties. So depending on the counties that have been scheduled, they happen in the either in the referral facility or in the level 3 facility. So it's normally communicated through the county director of health.
Okay. And Pauline would like to know if government hospitals offer radiotherapy services.
Yes, Pauline, we have KNH and MTRH as the referral facilities which have radiotherapy, as well as KU. And we have Nakuru, Mombasa, and Garissa, which also have radiotherapy services. And it's good to note that Garissa, the patient, the number of patients going there is still small. So even the wait times are very small. Maybe the rest of the facilities, you may need to wait 3 to 4 weeks to get treated, which is a big improvement from the 1 year that was there previously. But places like Garissa, you won't have to wait for long. So we encourage members to go there. Thank you.
And Odida would like to know if there's any facilities offering colposcopy outside Nairobi.
Yes, I don't have the true number and the specific facilities, but yeah, they're available outside Nairobi. They can check at the referral facilities, maybe around Eldoret, Kakamega, Kisumu, Nakuru, Mombasa. They should be there.
Okay. So Lillian Mutua is asking, is saying, kindly define the health promotion role in cancer program. And then can we have the health promotion teams in counties sensitized on cancer as an aspect of prevention promotion role?
Yes, so in terms of the counties, we actually have trained very many community health volunteers on cancer and just how to speak to the population on the need to seek screening services, on the need to adhere to treatment. So that has already been done and it's ongoing. And I think now currently the Ministry of Health is also rolling out the community health volunteers now under the full umbrella of the Ministry of Health. So they'll be equipped with all those information, including cancer health promotion. And even as a program, all the activities that we do, especially in prevention of cancer and early detection, we rely heavily on health promotion. We have messages circulating, we have posters circulating, and we have trained the advocates, including even our cancer survivors. We train them every January on the advocacy training for cervical cancer, and they're able to actually speak on this matter very confidently, even if some of them have a different cancer, but they're able to advocate for this cancer as well. Thank you.
Thank you so much, Dr. Catherine would like to know if Humphrey is continuing with follow-ups. Humphrey, are you still on follow-up? Not sure if Humphrey is still on the call, but someone anonymous.
Yes, I'm still in.
Yes, Humphrey, tell us, are you still continuing with follow-up?
Yeah, I'm still in. Okay. Okay, my question was with the issues of reproduction. So if the doctor can tell me how will the chemo affect the issue of reproduction after treatment? So that was my question.
Okay, thanks, Humphrey. You asked that question, but someone would like to know if you are still continuing.
Would you like to know, excuse, pardon?
Are you still on follow-ups or you are done?
Okay, nowadays I'm still going under checkup after 1 year.
Okay, okay.
Yeah.
So either Dr. Munyoro, would you like to take up the question on the bedroom thing that Humphrey wants to know?
Yeah, the question of fertility will be affected depending on what cancer you had, what treatment you got, whether you're still ongoing with treatment. Because at certain period of your treatment, then worry about quality. But I think it sounds like you've been off treatment for a very long time. So I don't, for him, I would worry. But there are those patients who, before treatment is started, there should be a way that will preserve your sperms or your eggs, something that will allow you to reproduce in the future. So it is actually one of the main things in survivorship that we have not gotten right, because depending on your age and depending on whether you do want to get children, it should be considered. You should be talked to it about. You should be told about what effects chemotherapy will have on your body, but most side effects will have worn out after many years. So for him, I don't think that he has something to worry about. But for a lot of survivors, there can be issues. So it is one of the things that we really need to look into. And currently, we have an ongoing course in oncology. I think once we are done, we should be able to give clear guidelines on what people should do for fertility when they are.
Dr. you are breaking. I'm not sure if we really got you, but anyway, thank you. So someone is asking, any inclusion on cancer and mental health? There's a lot around psychological, social, economical, emotional pain for patients, survivors, and family and health staff. So the issue of mental health again is coming up. Dr. Joyfrida, you want to take that up?
Yes, thank you, Sally. Yes, the issue of mental health, we truly recognize that as a key aspect to include in our program. So we normally collaborate with the mental health department under the Ministry of Health, and they support us in this. Although the area that I'm seeing is actively on this, and maybe Dr. Munyoro will confirm, is the palliative care team. I think so far they're the ones who have really taken up this role, and they're really doing a good job with our cancer patients. We know palliative care should kick in right from diagnosis, and we are seeing a good number of facilities implementing that, not like before where they would call the palliative team when, the patient is really not doing well. That is when they would call the palliative care for end of life care. But now when palliative care is started in good time, they actually cover the psychological, social, emotional pain for the patients and their families. And we've seen a lot of help for our patients. Maybe Dr. Munyoro will add.
I think what I would add is that we actually need to distinguish the roles. I think as a palliative care provider, I want to diagnose the psychological problem, and I want a counselor to help me. But now, so problematic. The problem is that in our training, when we started the palliative care KNH, end of life or supporting cancer patients was not part of their training. So we actually then started having the counselors come through our department. So I think there is a lot that as the ministry you need to do so that you get the training that the counselor needs so that they're able to support the survivor. So that, yes, the palliative caregivers are doing a fantastic job, but I think there's still so much we can do because, you know, palliative care is more about having an honest conversation with the patient, but the counseling will be for somebody to sit with you as you go through your mind and your ideas and, you know, so that I think we need to go into a position where we'll have two distinct people offering support for the psychological problem. So I think palliative care, they're doing a great job, but I wish every team in palliative care would be given counselors to work with them who are psychologists, who can then support even the team members of the palliative care team. Thank you.
Sally, could you ask Humphrey if he's still in the call? Has he actually asked his doctor about the issue of the effect of the treatment on the reproductive system? Has he been able to have that discussion with the doctor?
Yes, I've asked my doctor, and he told me that they are still doing research on it, that they are not sure, 100% sure, but they're still doing research on it.
Okay, all right.
Daktari, I think that is a gap that needs attention from what he's saying. And I don't think most of the patients, we have audience with our doctors to tell us that after taking this kind of drugs, the repercussions, or in future, you're going to have 1, 2, 3, 4, 5 because of this drug. And then I've heard Daktari say that there is a way that the ovums and the sperms can be preserved. Do we have that in Kenya? And if it is there, where is it available and at what cost?
Yes, we have it in Kenya. I know at least in KNH they had. Okay, how long? I would need to get back to you about the cost and also how long, you know, the storage facilities are there. But it is there and it is possible. So I think it's more for us to develop it because, okay, I used to have patients who would come. He has been diagnosed with cancer and then his girlfriend has suddenly left him. And of course, there would be a kind of a panic. And then they would start thinking that they're going to get infertility if they go through the treatment. So there used to be a lot of confusion. And I know at that time I reached out to the University of Nairobi, and I know the facilities are there, but I would need to get back to you and tell you exactly what is there, because for most of those patients, I then used to just note down their concerns and send them where they would get the necessary support. But I can get that information for you, or for the next time that we talk about survivorship.
Thank you very much.
Sally, are you still on? I'm seeing someone asked.
I think I muted myself. I'm on.
Oh, so I'll continue. There's someone asking about
Someone
this.
was asking about how come I had cervical cancer stage 2
Yes.
and I did not have any symptoms. So as I said, I am living with HIV, so I was being monitored very closely. And we know that cervical cancer is caused by some kind of the HPV. So I was screened for HPV and it turned positive, and that is when they did more tests. And then the pap smear realized that I had some abnormal cells. So when they did the staging, that's how they found that I actually had cervical cancer. I hope that answers the question. Someone is asking, and this I'll give it to Lucy. Lucy, there's a lady called Emily who is asking for sponsors to start a breast cancer support group in KNH Othaya. I don't think you need any sponsorship to start a support group. Maybe just someone to facilitate, to help you to actually bring the people together and do it. Or I
Yes,
don't know exactly to say sponsors.
you don't need any sponsorship to start a support group. You just need to have like-minded people who have gone through cancer treatment and are victorious among their champions. Probability, they are willing and they have healed enough that they can share. It takes a while before we open up after the diagnosis and treatment. People tend to go to their own cocoons and not speak about cancer. Get those people who have healed and are willing to share. Then form a group. We may have a nurse or a doctor amongst yourself. And once you start, you encourage each other, you share your stories, you support each other. And then the newly diagnosed patients, instead of being alone or feeling lonely, you welcome them in your group. And with time, the sponsors don't come. People will see what you are doing and they'll come back and they give you whatever they're able to give you, and they can support you. There are people who will support you with food. There are people who will support you with paying NHF for the patients. There are people who will support you with prosthesis. There's people who will support you with stomach bags. So we don't need sponsors to start. Start if you are 2 or 3 and you've healed emotionally that you can speak out without breaking down in front of other people. You are good to go.
Thank you, Lucy. So there's someone who's saying that it's a farm tech registration 09517 that I've been attending this meeting since January and I've never gotten even a single.
Kindly let us respond to the CPD questions kindly. Okay, to pick up from where Sally was commenting on the CPD, or rather the questions we received on the CPD points. Please note that for PPB, there's actually a process for all of this to happen. This means that you must subscribe for the session on the portal and also appear on our attendee list. So the process is you should subscribe to the event that is uploaded on the PPB portal first before claiming your points. So the reason for most of the people not receiving their points is because the subscriptions are not matching the names of the attendee list. So we are unable to send any CPD points to you unless they match the numbers of the attendee list. That is why we always encourage you to visit the portal and subscribe to those points. So for that, we do know that some people who have subscribed to the sessions, but there's still a group of other attendees who haven't managed to subscribe yet. So kindly visit the portal, subscribe for the events, and then you will be able to receive all your tokens. Thank you.
Thank you so much. So someone, Josephine is asking, can KNH and UoN be able to notify the healthcare workers on the upcoming oncology trainings? Putting in consideration not all healthcare workers are in public setting, maybe through the emails provided for webinar alerts. I don't know who will take that up.
And also respond to the same. We normally send out notifications on upcoming meetings. That is on WhatsApp and also through email. So any that will be concerned, we also update the schedules on the Zoom portal. So all of these are available for you to take a look, and you can know which sessions we have on upcoming.
Thank you. So there's someone who's asking, we have health promotion officers in all 47 counties who have diploma or higher diploma in health promotion. Can they be given a chance to train and not as community health volunteers? Dr. Chepchumba, sorry.
Okay, that is well noted. I think we can consider that in the next trainings to incorporate them. Thank you.
Thank you so much. So,
There's the question by Grace saying, what are the differentials if one is symptomless? So that is connected to the cervical cancer diagnosis at stage 2. And I think, Sally, you've answered. You've said because of the frequent screening you used to do, that is how they're able to note the change in your cells, and that's how the diagnosis was made. So for HIV positive people, every year you need to do your cervical cancer screening. Then for the HIV negative, every 3 years at least you need the cervical cancer screening. Okay, thank you.
thank you. So someone is asking, how can one be assisted when they test positive for cancer screening if they don't have money to go for further tests, or do we have any free services at KNH?
If you have, for this, you need at least, if you don't have money, you need at least to pay for NHIF. NHIF will cover for the treatment services. But I don't think everything will be free without NHIF, but at least with NHIF, you'll get many of the services without adding any cash.
Okay, there was one question.
Sally, let me add something on that. It's good to have a good support system from your family and friends, because treatment for cancer, it's very high. The cost is very high. Even with the NHIF, you still need to do out-of-pocket payments. So I usually tell people, let's appreciate our people when they're still alive. Let's support them and give them love at that particular time. But in our African culture or nature, let me say that we really appreciate people when they die. Is when you can afford a coffin costing 70,000, and this person needed just 20,000 to do a specific test. So can we start supporting our people from our family, from our community, so that when you go to Kenyatta and somewhere you are stuck, there's the social office, and they see that you've been trying. So kindly, if there's that person in your community or you are the person, please, let's come in for our people. Thank you.
Thank you so much. Kevin is asking, considering the sensitive nature of cancer diagnosis and the potential legal implications, are there any existing legal documentation or policies that govern the use of AL-based diagnosis for cancer? What safeguards or guidelines should healthcare organizations and professionals follow to ensure ethical and responsible implementation of all technologies in cancer diagnostics? Dr. Joyfrida?
Yes, there's the Data Protection Act. Is it 2020 or 2021? Yes, that covers that. So yeah, we can refer to that.
Okay, thank you. So Lillian is asking, I think this is the last one. Who else is being engaged in the forefront of supporting survivors and their significant others other than the clinical nursing and palliative team? Support includes preventive, promotive services and advocacy. Community activation, engagement, and mobilization is core to give support at a 360 degrees. I think this question was answered during the presentations. Or Dr. Esther or Chepchumba, you'd want to add something on it?
I'll just say, yeah, we totally agree. I think we've made it in the presentation that there's the role of the clinical team, there's the role of the community and the family, and part of the work that we do, even with the support groups. I believe the support groups, even the palliative team, they actually go down to the families to talk to them, to guide them on how to support these patients. So yeah, the mobilization is actually being done to all. And even events such as what we had yesterday, we actually did like a community activation. We walked through the town, just sensitizing people about, cancer survivors, showing them that cancer is not a death sentence. There is still hope even beyond the diagnosis. You can be treated and actually continue with life. So there's involvement of all parties. Thank you.
Thank you so much. I think we'll end the webinar from there. I really appreciate the attendance. I've never attended a webinar that has so many people like this, 1.5K. I would wish that you call me to the university to speak and share my story, if you don't mind. I want to thank Dr. Joyfrida Chepchumba, Dr. Esther Munyoro, Lucy Njeri, and Humphrey Ajwang for your time and your presentations. People have left here with a lot of knowledge. And yeah, let's do this again. Thank you and have a nice evening. Bye.
Okay, bye. Thank you all.
Thank you once again for your presentations and also the talk. This is Nelson from KNH Research. I would like to further address the issue on CPD points for KMPDC, which I have received a couple of questions. So kindly please note that for KMPDC, your board number and your email address that you have provided on our platform should match the board number and the email address on the ICPD portal. Otherwise, the system won't be able to pick up your details. So kindly just make sure that they're the same. We had earlier sent a link for registration to update the details. If you still need the link, you can send us an email at knhresearch@gmail.com and we'll be able to resend you the link so that you can update your details as per the ICPD portal. For any other issue regarding the CPD points, maybe you haven't received CPD points in the last few weeks, kindly email us with those specific events that you did attend and you haven't received the CPD points on, so that we can follow up with our team, the team on our side and also the ICPD, and we'll be able to assist you to receive the tokens for the sessions you have attended. For COC, kindly note that we're still following up with the COC Council so that we can be able to harmonize both systems and send you. Currently, we are working with sending the attendance list to the COC so that they can be able to do the uploads themselves, but we are working on a solution so that we can be sending the points ourselves from our end. For Nursing Council, also the same. Please expect the CPD points through your emails. This will be provided as soon as the codes have been generated from the NCK portal. So we'll be sending them, and in case you have any complaint or follow-up, kindly just email knhcpd@gmail.com or knhresearch@gmail.com. Thank you once again for joining us for today's session. We'll be back next week with a session on the 14th. That will be to reproductive genomics. You are invited to join us, and also you can share our link with some of your colleagues so that they can also get to learn more from this platform. Thank you and do have a wonderful evening.